breast cancer screening for women aged 40 to 74 who were not at increased risk of breast cancer. Breast cancer screening has undergone many changes over the past couple of decades. When I first moved into an advanced nursing role in the 1990s, the teaching was that women should do breast self-examination every month after their period. Now on to clinical breast examination, or CBE. Speaking only to the question of screening low-risk women for breast cancer, practitioners at my clinic follow the Canadian Task Force on Preventive Health Care's recommendations. This Canadian Task Force on Preventive Health Care advises not performing clinical breast examinations for the purposes of screening. There is no evidence that it has an impact on breast cancer mortality. Should someone present with a concern about their breast, of course, you will do an examination, but that is a clinically focused exam and not a screening exam. This is how I approach breast cancer screening in my practice. When I do a periodic health exam with a woman of any age, I ask her if she has concerns about her breasts. If the answer is no, then that is the end of the review of breast-related symptoms. If yes, I ask about symptoms including lumps, skin changes, and nipple discharge. A clinical breast examination is done starting on the asymptomatic side, so I have a baseline to compare the other breasts to. Additionally, for women over age 40, I review the 1,000-person tool with them and have a conversation about mammography screening. I still talk about the importance of knowing your breasts and recommend following up if they develop any concerns. I take the person's values and preferences into consideration when making or not making a recommendation for mammography screening. When 1,000 women aged 40 to 49 are screened for breast cancer, less than one breast cancer death is prevented. The 7 women diagnosed with breast cancer. 294 women will have false positive test results, 43 will have an unnecessary biopsy, and 3 of the 7 diagnosed with breast cancer are in fact overdiagnosed. That is, the cancer would have never caused a problem. From the age of 50 to 59, the same number of women will have a false positive, 37 women will have unnecessary biopsies, and 1 breast cancer death is prevented. 12 women will be diagnosed with breast cancer, 3 as a result of overdiagnosis. For women aged 60 to 69, 256 women will have a false positive, 35 women will have unnecessary procedures, 21 women will be diagnosed, and 1 breast cancer death will be prevented. A study from the New England Journal of Medicine looked at the impact of mammography screening over a 30-year period from 1976 to 2008 in the U.S. An almost twofold increase in the detection of early-stage cancers was noted, only a small decrease in late-stage disease. So what does this mean? Our knowledge of cancer biology has changed over the past 30 to 40 years, and we now know that not all cancers are life-threatening and that if left alone may not be harmful. In the case of the diagnosis of early-stage breast cancers, the authors found that breast cancer was overdiagnosed in 1.3 million U.S. women during the 30-year study period. Blair and Welch found a larger relative reduction in mortality among women who were not exposed to screening mammography than among those who were exposed. Of course, there are limitations to the study. For example, including the years they chose as the before cohort, the inability to effectively control for hormone replacement therapy as a factor, and assumptions had to be made for incidence if there were not screening programs in place. But the data is compelling despite these and other limitations.